So today we'll hear from two speakers. Each presentation will be 15 minutes. We have two speakers representing a case in Uganda and one in Kenya. I'll introduce them later. Each of the presentations will be 15 minutes, and after that we will have about 20 minutes for your questions. When you think of a question, please put it in the Q&A box. We have a Q&A box. You can see it on your screen. Please don't use the chat box for your questions. Let's restrict our questions to the Q&A box. We will have time to answer those. And please just click on the Q&A box and enter your questions. We will answer all the questions after the presentations are made. So just be patient when you put your question in the Q&A chat, in the Q&A box. You can also vote on other participants' questions by clicking on the little thumbs up. Okay. So when somebody's putting a question that you also wanted to ask, just put a little thumbs up to the same question, so we know the number of people sharing in the same question. So we'll get started. It's my pleasure to introduce our first speaker, Lominito Mark Lomoru. Lominito Mark Lomoru is based in Kenya. He works for Save the Children, and he is the Health Systems Strengthening Advisor for a USAID VHA-funded activity called Nawiri. It's a Kiswahili word. Lominito's Nawiri activity is based in Turkana County of Kenya. You can read more about Lominito in the Hoover event app, for which you are all subscribed. So I will give Lominito this platform to take it with the presentation. Please do enjoy it. Both presentations will be giving us some interesting adaptations on child nutrition screening and community health system strengthening during COVID-19. Welcome, everybody. I'll have Lominito take the platform.
Great. Welcome, everyone. I am Lominito Lomoru, the Health System Strengthening Advisor for the USAID Nawiri project, based in Turkana, Kenya. I'll be talking about COVID-19 adaptations to strengthen communities and health systems in Kenya with a case of the USAID Nawiri project. More about USAID Nawiri is that USAID Nawiri is development project. Maya?
Yes.
Yeah, I seem not to move.
It's this is it says that you could, tells me that you can do it.
Sorry?
It says waiting for, hold on, let me try this. Okay, I will stop and now I'll give it to you again. Try now.
Yeah. The slides do not seem to be moving.
It's still not. If you go down to that corner again with your mouse, to the corner of the screen where you have those little arrows should appear. There you go. There. Okay, and just do it from the beginning and pretend that James just said, handing over to you, Lominito, take it away.
Yeah. Thank you so much, David. Thank you so much, James. Welcome, everyone. We'll talk about COVID-19 adaptations to strengthen communities' health and communities and health system strengthening in Kenya. And my name is Lominito Lomoru, the Health System Strengthening Advisor for USAID Nawiri project. More about USAID Nawiri project is that USAID Nawiri project is a USAID funded development activity that is focused on sustainably reducing persistent acute malnutrition in children under 5 years in Turkana and Samburu counties of Kenya. It is working with several partners. We have Center for Humanitarian Change, which is looking at how learning and adaptations are happening within the project. We have Research Triangle Institute, which looks at collecting evidence and research and analysis of data so that it informs interventions around prevention of persistent acute malnutrition. We also have Caritas Lodwar, which deals with water, sanitation, and hygiene. We have the BOMA project, which looks at strengthening economic aspects of women, empowering women with economic opportunities. And then we have Save the Children, looking at the health and nutrition component. And then we have Masico, which is the lead for this particular project. So together with all those components, the project looks at seeing into it that there is a reduction in persistent acute malnutrition in children under 5 years. And talking about the context of Turkana and Samburu counties, Turkana and Samburu counties are in the northern part of Kenya, and they're in the northern part of Kenya. And as you can see in this map, we have Turkana County, which has 7 sub-counties, small administrative units. And then we have Samburu counties up here, which has 3 sub-counties. So it's all in the northern part of Kenya, which is largely a arid and semi-arid area. What is being practiced as an economic activity, kind of livelihood, is mainly pastoralism, where people move from one place to another. So with that context, we have had, with that background, we've had COVID-19 situation in the country, and several measures have been put by government and the Ministry of Health, including social distancing as a measures to need. However, this has been able to limit people access to health services, in that the healthcare facilities are becoming overstretched as healthcare workers continue to be able to see more patients and need more time to screen even those patients who are coming to the facilities. Also is that Nawiri is employing an approach of a multi-level system strengthening, such that we are looking at different levels of healthcare system within the county. Of course, there is the national level, but we also have a county level, national, which constitutes of the managers at the county level, implementing partners. We also have the health facility level, and we have community and household level. So USAID Nawiri did respond to the COVID-19 context, looking at ways of intervening, but then looking at also ways of controlling COVID-19 transmission while building the systems in the long term, but also looking at what we could do in the short term. So at the county level, USAID Nawiri was able to collaborate with partners. USAID Nawiri was able to collaborate with partners by getting partners on board, the implementing partners such as the UN, UNICEF, World Food Program. We have other implementing partners funded by USAID like IRC. With all these partners and government together, we had to collaborate and come up with engagement with COVID-19 interventions that were designed to look at the lower levels of the healthcare system, the health facility level, the community level, and the household level. And so all those interventions that were designed in structures that exist within the county level. We have County Nutrition Technical Forum, which where all aspects of the response in terms of health and nutrition, including the adaptations from the national level, are made and tailored to the 3 levels of the system. Also, we had the multi-sector platform for nutrition, which constitutes of several sectors that are looking at both nutrition-sensitive programming and also nutrition-specific programming. So from the nutrition-specific aspect, where we have the health component, we also have the nutrition-sensitive aspects like sectors like agriculture, water, livestock, all these, education, all these coming together to discuss issues of nutrition and the interventions that are beyond, within and beyond the Ministry of Health. But one major component that in terms of our adaptation was coming up with the learning sprint model. The learning sprint model, in the learning sprint model, we were able to have a way in which we could look at interventions. We implement those interventions and then monitor those interventions. Over time, look at our COVID-19 guidelines implemented. What is new in what is emerging in the process of implementation? What are the fears from the community in terms of even accessing services? And then we reflect upon these findings or observations from the field and come up with adaptations that will then be implemented at the field level as an activity. So in this learning sprint approach, we were able to learn, implement, reflect, adapt, and be able to come up with new activities that will then enable us to respond to the COVID-19 context and be alive to the changes that needed to be done to enable communities take up services and also be able to prevent COVID-19 transmission. So at the health facility level, we were able to implement a model called the Integrated Management of Acute Malnutrition SAG model. So all the facilities where we were responding to, we had to look at how do we then have a mechanism of picking, a surveillance system of picking COVID-19 cases by looking at the thresholds of each health facility, including we had an adaptation around getting COVID-19 as one of the comorbidities that would be measured within the COVID-19 situation by the health facilities. So because facilities were looking at their thresholds in terms of the number of malnutrition cases that were coming up, looking at pneumonia cases, looking at diarrhea cases and malaria cases. So with all these, we added COVID-19, such that it was now easy for facilities which were able to meet higher thresholds. Then we will now look at the health systems approach, whether it was staffing, a facility that needed, because of increased cases that needed more staff, or healthcare facility that needed more commodities to be supplied to the health facility, or facilities that needed to, skills building for the healthcare staff. So we use this model to service, so this model serviced several issues within the health facilities, and we were able to respond to it with all that Imam Saj model. But central to all this was building the capacity of healthcare workers through coaching and mentorship, and so that they will now be using the Imam Saj model to be able to respond with the key decisions that they have made, but then being empowered with the skills on how to make those decisions. At the community level, USAID Nawiri was able to build we used the community health strategy framework, which is a framework for community engagement within within Kenya. And central to community health systems is community health volunteers or community health workers who undertake a critical role in ensuring that households seek healthcare services, they understand what services are available, and in the context of COVID-19, they understand COVID-19 prevention measures, and they are able to access health services whenever. One of the challenges within the COVID-19 context was that households or communities around Turkana and Samburu had myths and misconceptions about the transmission of COVID-19. And so they primarily pointed out that health facilities were the key source of COVID-19 transmission. So community health volunteers then helped, were equipped with this knowledge so that they were now able to have dialogues with the community through mini dialogue sessions. The mini dialogue sessions were tailored because the national government gave out guidelines that there should be no public forums. There should be no public meetings of more than 15 people. So we used this directive to adopt and enable community health volunteers to have community mini dialogue sessions of less than 15 community people, and with one community health volunteer, where they discussed issues around understanding COVID-19, what transmission routes exist, and prevention measures of COVID-19. So with all these, the community health volunteers were able to sensitize communities and give them information and give them the low risks that exist when it came to seeking healthcare services. Of course, we had to train community health volunteers on COVID-19 prevention. We also gave them, in terms of COVID-19, the county government with Nawiri supported the CHBs to have equipment, protective equipment, masks, sanitizers, and also helped them to place hand washing stations to strategic positions within the community, including at the household level. So with all these, we also had to train community health volunteers on the skills of identifying, treating, or referring children under 5 years in using the integrated community case management approach. So in this, they were now able to detect and refer these cases to the health facility. Of course, including communication on how to prevent these conditions. We also had to train community health volunteers on management of acute malnutrition, the CMAM, at the community level. So they were taken through that guideline. But the most important aspect was training community health volunteers on family-led MUAC, which is the mid-upper arm circumference strap, which is color-coded, and then this color-coded strap allows the community health volunteers to be able to identify which children are severely malnourished if they are in the red color-coded, or moderately malnourished if they are in the yellow color of the strip. And of course, continue giving nutrition education to mothers whenever those children are also at the risk part of the strip. So they are also expected that once we train them on COVID-19 and we gave them these community health volunteers did continue treating and referring sick children, but also they went ahead to train mothers on family-led MUAC. But in all this, one of the enabling environments for community health volunteers that needed to be adapted to was enabling them to ask questions, ask clarifications, because it was not possible to bring all of them together. So we had an adaptation around the use of WhatsApp messaging. So community volunteers developed groups And in those groups, they opened the WhatsApp pages, and they were now engaging. They were asking questions in Kiswahili, the local language, and sharing with their supervisors, the community health assistants. And they would ask questions on what they need to do when they would be faced with a situation like if they didn't understand something about how to treat a child, or if they found a surprising situation, if they found, say, for example, a child who is severely malnourished, they will take a photo, share on WhatsApp, and ask for an immediate response was given by the child and the other technical people within the project. And the community health volunteer will be guided so that their capacity will be built and they will be enabled to work more comfortably. So WhatsApp messaging really was a good innovation during the COVID-19 situation. At the community health, at the household level, from the community health level, we moved to the household level, where at the household level, at the household level, the community health volunteers were now able to teach the household members, especially the caregivers, whether it was the mother or the grandmother or the eldest person or the eldest sibling in the household. They were all trained on the use of the family-led mid-arm circumference trap, and this training helped households to be able to assess the nutritional status of the under fives by using that strip. And so more than 2,000 households were reached with the family-led work training, and the community health volunteers, other than training, on top of training households on the use of family-led work, they also instructed them for this kind of a child, they would be able to refer them, like be able to check on their mid-upper circumference at least every month. And for a child who would be found to be severely malnourished, then they will organize with the CHV. The CHV will find a way of managing them at the household level, or if it's severe with all these complications, they will be referred to the health facility for the therapeutic treatment and information sharing, especially on the prevention of malnutrition. But then also at the household level, we found an opportunity to work with households such that they would have family level meetings. More important was about the discussion around nutrition and a household capacity to buy some of the nutritious foods from the market. And as we all know about this, as we all know about the Turkana Samburu communities, is that they are patriarchal communities. It is the household head who is the father or the man of that particular house is usually the sole provider, and is a key also decision maker when it comes to the resources available for the household to make or to buy food. So while it will be the role of the mother to buy household food items, the father would also be able to provide the resources needed for that. So we found it necessary to have dialogue within the household such that key decisions will be made about diet, the nutritious diet and how available it is for the household. One of the challenges we found during these family-led level meetings is that the fathers were not available, especially in the morning when the trainings were happening or when the discussions were happening. So we missed them in those trainings. And so in those discussions, those family level meeting discussions. So we had to quickly adopt by changing the time to be able to then, by changing the time, such that in the afternoons is when we now had, or the families the fathers at home in the afternoon. And so most of the meetings now are adapted to happen in the afternoon. So with all these three levels that we have discussed, we learned that so much could happen with the family level meetings in terms of sharing information. We also came up with the cooking demonstrations, and overall, with the community strategy approach, the household level approach, we saw that there was about 16% increase in referrals to health facilities, and people now are beginning to use the services at the health facility, which was a good observation in terms of the positive impact. So what are we learning? What is the key lesson that we have learned in implementing a system strengthening approach? It is that while we were developing interventions, we put in mind that yes, these interventions were long-term interventions to address the effect of the COVID-19 as a pandemic. But then some of these interventions are also going to have a long-term effect in terms of strengthening the health system. And also the other lesson is that we need to continuously assess the situations, we reflect, adopt, and be able to strengthen the system in that regard. With that, thank you so much. Thank you again. If you want to know much more about this presentation, kindly, with the link provided, you can get to me and I'll get back to you. Thank you so much.
All right, so hello, my name is Robinah Nannungi, and today I would like to tell you about how Graduating to Resilience activity collaborated with local stakeholders to adapt our child nutrition screening during COVID-19 lockdown back then in 2020. To tell you a bit about Graduating to Resilience, this activity is a USAID Bureau for Humanitarian Assistance funded activity. It's led by AVSI Foundation in partnership with Impact International and Tricolab. The activity is using the graduation approach, which is an integrated, time-bound, and sequenced set of interventions that are designed to progress ultra-poor households out of extreme poverty into sustainable livelihoods and greater resilience. This 7-year activity engages 13,200 households in Kamwenge district, that's in Western Uganda, and 50% of those participants are refugees from the Democratic Republic of Congo that are living within Ramwanja refugee settlement, and the other 50% are from the surrounding host communities. While these households are economically active, they are unable to consistently meet their basic needs without some form of assistance. In response to the COVID-19 pandemic, the government of Uganda instituted a countrywide lockdown back then in March 2020 that included a ban on public transport and large gatherings, including activity-run groups like the Village Savings and Loans Associations, our famous VSLS, which are a key part of the activity, not only for savings, but also for child nutrition screening for those participants in the group coaching treatment arm. All non-essential shops, meaning those that are non-selling food items and necessities, closed. And additionally, price hikes and reduced access to food and necessities combined with reduced incomes resulted in greater food insecurity. This growing concern regarding food security put the Technical Steering Committee, that's the TSC, which is composed of technical advisors and the managerial staff that are responsible for decision-making to a test. When the regulations were put in place, the Technical Steering Committee, which is the TSC in short, first conducted context monitoring through remote data collections. We had 2 rounds of assessments conducted to monitor participants' knowledge, their experiences, and market conditions. This information allowed the TSC to make key decisions, such as whether to provide cash safety nets and what key messages to send out to participants via SMS. According to the activity context assessments, we had 88% of households that took steps to prepare for COVID-19 lockdown. And of those, we had 98% that said they did so by storing food. However, as mentioned previously, the transportation restrictions limited access to health foods, and business closures reduced income for participants. And as such, the Technical Steering Committee, the TSC, feared that households may opt for negative coping strategies like reducing meal sizes, frequency, or food quality, thus threatening childhood nutrition outcomes. And adding to these fears, due to remote implementation, monthly nutrition screening could not take place. Actually, even after the restrictions were relaxed, nutrition screening was not possible as Ministry of Health guidelines required sanitization of the equipment after each and every client assessment. And all nutrition monitoring was to take place at health facilities because they believed health facilities are more in position to really ensure the guidelines are put in place, the SOPs are put in place. And we, the Food Security and Nutrition Technical Advisors, first addressed concerns about malnutrition by training coaches. Coaches are the direct implementers of the activity, to teach participants how to identify the signs and symptoms of malnutrition in their children and report concerns of suspected cases during the remote coaching sessions. However, this approach was not successful as the number of referrals dropped from 13 moderate and severely acute malnutrition cases in January-March 2020 prior to remote implementation to only 3 cases in April-June 2020. We decided to have a spot check of randomly sampled coaches, which revealed the approach was easy to administer and empowered participants. However, it was ineffective because participants felt shame and were hesitant to admit remotely that their children might be malnourished. I mean, I'm with you on phone and you're asking me, does your child have symptoms of malnutrition? It's hard to admit. As the first idea was not successful, the TSC went back to a drawing board. We were determined to continue child nutrition screening despite COVID-19 regulations. We applied knowledge from case studies of family mid-upper circumference approach, which is MWAC, to develop a detailed standard operating procedures, SOP, for graduating to resilience activity. Family MWAC is an approach where caregivers are trained to screen the nutrition status of their children. This we adapted as a graduating to resilience activity, having a coach observing at an acceptable social distance to ensure quality. The SOPs detail the necessary collaborations with local stakeholders for the successful rollout of the family MWAC, and the prior relationship with Medical Teams International, MTI, that's the main health partner in the refugee settlement, was necessary to the nutrition screening adaptation. At the time of this adaptation, UNHCR and Office of Prime Minister declared only health providers could operate physically in the refugee settlement to provide life-saving services. And as such, graduating to resilience technical advisors were based remotely and had to rely on MTI nutrition personnel to support the training of the activity program officers. And through collaborating with this local partner and the government of Uganda, we were able to scale the family MWAC approach. MTI personnel trained activity program officers in family MWAC, who then trained field-based coaches and government village health teams, the famous VHTs in the refugee settlement and surrounding communities. Coaches and VHTs then conducted the training for activity participants. Additionally, the activities relationship with the district officials was essential. We sought the support of the district health officer, as Graduating to Resilience was among the first in the region to implement the family work approach. The DHO was exceedingly supportive, and this support was integral to acquiring over 4,600 mark tapes. While AVSI's relationship with the DHO improved this process, acquiring this number of tapes was no easy feat and required the DHO approval to receive the tapes from the regional hospital and from MTI free of charge, as this cost of this equipment was unplanned and thus not part of the activity budget. Without support from the DHO, acquiring the mark tapes may have been impossible. Due to the tremendous support of the DHO, the mark tapes were acquired. And additionally, because of the collaboration with MTI, AVS personnel and VHTs were trained, it was now time to distribute the tapes to participant households. The activity prioritized the distribution of the tapes to participants with children under 5 and those who had malnutrition history. Coaches distributed the mark tapes to the trained participant households and family work began. According to the SOP, screening would take place once monthly in the presence of the coach, monitoring from 2 meters distance with a mask on in accordance with the COVID-19 regulations. Parents would use the mark tapes on their child's mid-upper arm and report the measurement to the coach, who would document the information and make a referral if necessary. Parents were requested to conduct the screening more regularly and report issues to activity staff or the VHT. We see the success of this approach in the increase in the number of children referred for support from 3 using the signs and symptoms approach to 24 using family work. The approach was embraced by participants, thus screening a total of over 3,300 children in just 2 months. Despite this success, the rollout had its own challenges. Even though our coaches lived in the same communities as our participants, we still had to wait for some regulations to ease as we started planning for family work during a complete and total lockdown, where no one could move except for essential purposes. Finally, teaching participants who were often illiterate to read the mark tape was a challenge. While most could read the numbers representing centimeters, teaching participants to read all the millimeter marks for documentation purposes was a challenge. From a distance, coaches overcome the challenge by asking participants to just count the number of sticks, and so they would document. To overcome these challenges, Graduating to Resilience personnel underwent a mindset change during the initial stages of COVID-19 pandemic. When restrictions began to increase leading to the full lockdown, our first reaction was there's nothing we can do. However, as we studied the data from our context assessments, conducted the first scenario planning exercises, and learned from other organizations, in just 2 weeks' time, our thoughts changed to let's try, see what happens, and go from there. From that day forward, the mindset of all staff has been more open to new ideas, more flexible, and more willing to accept failure as an option. And because of this shift in mindset, we were able to measure immediate results of the family work approach because of the number of children being referred for nutrition services. And increasingly, when MTI compared cases in the health facilities and those in the communities during monitoring visits, there's greater consistency since family work was implemented. During an interview with a senior nutritionist at MTI, she reports an increase in referrals for nutrition services and can attribute this to the Graduating to Resilience family work approach because the activity is the first in the area to conduct this type of child nutrition screening. She reports that by the time MTI went to conduct family MWAC training with households in the area, people already knew how to conduct the MWAC nutrition screening measurements on their children. Despite COVID-19 challenges, there has been a tremendous reduction of 30% in MAM and SAM cases identified in 2020 compared to 2019. We attribute this decline in the number of cases to improved nutrition practices resulting from coaching. This is further supported by participants' self-reflection assessment scores, in which 94% of the participants reported performing extremely well in meeting their food security and nutrition needs. Additionally, the June 2020 context assessment indicated no participants reduced meal portions for children 6 months to 5 years of age as a coping mechanism during COVID, reflecting uptake of infant and young child feeding practices. These factors, combined with family MWAC, account for a continued decrease in child malnutrition cases. As of June 2021, participants continue to take lead in monitoring their children's nutrition status. Finally, during a monthly Ministry of Health, Nutrition and Emergency Coordination meeting, we shared our approach to implementing family MWAC, the challenges and lessons learned. The ministry has since started pushing for a wider rollout of the family MWAC approach, and we are contributing to the national guidelines. The USAID local systems framework states that achieving and sustaining any development outcomes depends on the contributions of multiple and interconnected actors. Our experience scaling family MWAC during the COVID-19 pandemic and subsequent restrictions was only possible because of the existing positive relationships, as MTI supported the training of graduating to resilience personnel, the VHT supported the training of participants, and the DHO helped the activity obtain the MWAC tapes free of charge. Without these existing relationships and collaboration, the rollout of the family MWAC approach would have been exceedingly more difficult and perhaps impossible. Instead, we worked together to overcome the extraordinary challenge faced globally and created a solution that will empower communities to monitor their children's health for years to come. If you'd like to hear about our family MWAC approach in collaborating with local stakeholders, my email is on the slide right there. Thank you.
Yes. You're not seeing anyone.
Wonderful. Thank you. Let's stop share.
Yeah, that's perfect.
That was perfect. Perfect. And no internet interruption. And you
Internet is not serious.
Perfect. Thank you. Thank you so much. We'll just cut it in, edit in the video. And I thought that we could send it out to those who came. We had a lot of people coming to the session. It's one of the most attended sessions in the whole event. So I thought we could send it to those who came. I can send a little special message saying thank you so much for coming. And we know we had some technical issues, but for a full video of the presentation, if you want to check it out, and then send the link to the video.
Perfect.
Great.
All right.
Thank you, everybody. I'm gonna go get some coffee.
Thank you.
All right.
Go back to sleep.
Yeah.
Thank you. Thank you so much for preparing and for all the time you spent on it. Really appreciate it.
Thank you. It's our pleasure. Thanks.
All right.
Thank you.
Bye. Have
Bye.
a good rest of the
Bye,
day.
everyone.
Bye.
Q&A session. There's a number of questions in the Q&A box. some have been answered, some haven't. So I'll pick on some that still need responses. I'll start with Rose's, which was partly answered by Titus. Rose would also like to know, Rose asked what virtual learning platforms were used for remote training, and Titus said, they use WhatsApp, but she also would like to know what were some of the key challenges that arose and how were those addressed? Any surprises in switching to remote training? Lominito? You're on mute.
Yeah, I didn't hear you.
So one of the questions asked by a participant, Rose, is, were there any surprises in switching to remote training?
Yeah, what surprises did emerge in the course of building the capacity of healthcare workers and community health volunteers? Yes, there were a number of surprises. One is that community health volunteers, for example, did really did not really pick up the virtual trainings very well, because what the models that have been used for demonstrations in the virtual trainings, in the videos, were not appropriate to the context. So they were always like, well, but this is not someone within our like, this is not how we do it. And so we really had to go back again and do adaptations in terms of getting the videos that were within the context, like within the Turkana context, with pictorials and with all these translations that depicted the local content. So that allowed them to be able to pick up materials, very well. Also, surprises in terms of, not really a surprise, but then others were really glad that even in the midst of COVID-19, they still were able to gain skills and be mentored and are allowed to practice new skills without the presence of a facilitator or a teacher. So I think that is basically what I can say.
Thanks, Lominito. There's another question about whether there was any specific methods deployed for differently abled or disabled persons or children.
No, in terms of screening for differently abled children, they are not different methodologies for such. They are the same. If, for example, a child has a contracture or has a disability of, say, the right arm, when it comes to MUAC, we use the left arm. So it's not the methods are there, which can be used for all the children.
Right. And Robinah, you share the same approach?
Yeah, sure. Yeah, similar approach really. No really specific mechanisms for the disabled.
Okay, great. Let me pick on another question. Somebody's asked, did you have challenges visiting the households because COVID-19 kind of put fear in families? So I'm wondering whether in your case, households really accepted your CHWs into their homes without difficulty.
Yes, COVID-19 came with...
Let me have Robinah go first.
All right.
Lominito, yes.
Yes, thank you. I think we didn't really get challenges that much. The acceptance that we got from the participants was because we stayed in touch with them. From the beginning of the pandemic, we talked about the context monitoring that we did when the pandemic set in. We kept asking them about their experiences. How is it going? What's changing? What's happening? What's not happening? So we really stayed in close touch with them. And that made them appreciate and gave them the feeling that we are in this together. Plus, the coaches that worked with them before the pandemic, that still continue to work with them remotely, had really established a good working relationship. They are part of them. They come from their communities. So they are not really strange people from wherever. They are part of them, and they are people that they have lived with. So acceptance was not that big much a challenge. Though, of course, you can't deny the fact that there could have been some fears around it, some of them given the spread of COVID and all that. But yeah, I would attribute the acceptance to the latter.
Thanks, Robinah. Lominito, let me point you to a different question. Somebody's asking how the training was conducted for individual households or groups under COVID. How was the training conducted for individual households or groups under COVID-19 prevention protocols? And also asking if it's possible to share the slides. But I can see Andrea is answering that question, Andy for Uganda, but you could chime in for your Nawiri experience.
Sorry, I didn't get you.
So someone's asking how the trainings to households and groups were conducted under the under the COVID-19 protocols.
Yeah, thank you. For the training of households, we trained households on the family-led work, and the objective was to really minimize contact of the household members with the other household members, because that will then increase the risk of COVID-19 transmission. And so there was a face-to-face training for households where a trained community health volunteer would then go to their own registered household and then be able to conduct the household training for the same household household members. So that then allowed a minimum risk transmission, because then there was just one CHV and only the household members for that particular house were trained. Thank you.
Thanks. Someone's again another question: how did families deal? How did families without mobile service connection and access or internet? How did you deal with those kind of families?
Is that to me?
It's to Titus. But Robinah, you can take that.
Yeah, sure. There are definitely challenges with network connectivity, not necessarily actually internet, because the model was really through the remote sessions were through phone calls. So there were definitely internet connectivity, but we tried to address this by coaches making prior appointments earlier on, so the participants, even within their homes, they could really know that, at such and such a time, I have a coaching sessions with my coach. And so they get to a better internet, a phone connectivity spot. Same for even within the group coaching. Still, we had participants in mini groups where we would do teleconferencing for them to receive coaching sessions in their mini groups. So really, the prior appointments that the coaches do with the participants were key in the participants preparing and identifying better network spots within their areas to go ahead. Even when the movements allowed, when the guidelines were relaxed a bit and they could move in that situation, you would see either groups shifting locations to better network connectivity spots and stuff like that. But they were definitely—
Thanks, Robinah. And
yeah,
thanks. And following on that, there's a question from Pearl asking, did you give nutrition interventions such as food support? And if yes, for how long? And how did you sustain the support?
We actually didn't. We didn't give supplements or nutrition interventions in terms of food at that point. In my presentation, I mentioned that within the context assessment that we did, in the start. We wanted to get to understand, is this really necessary? Is it something that we want to do? And as we continued with the context assessment, we realized, surprisingly, that the participants had actually prepared for COVID-19 in different ways, including, I mentioned 88% mentioned that they had prepared, and 98% of them mentioned that they did that through storing food. So the food support, the direct food support wasn't really rendered necessary following the context assessment that we had as an activity. And plus at that point in time, we had reached at a point where our consumption support, which was designed to be provided at 12 months, was but either way, the assessment didn't really call for that need.
Thanks. And let me ask one last question so that we wrap up. There's plenty of them. And thanks, Andy, for trying to take on some of those in the chat. I think this is more for AVSI. Do you have any contingency plan for graduates if they slide back to the original situations? The resilience graduates. Robinah or Andy?
I can answer that one. I think one of the great things about the Family MUOC approach is that we're enabling the parents and guardians to continue the nutrition screening for the long term. And so while this was an adaptation that we made because of COVID-19, it's one that we are going to continue, we're continuing to do even after COVID-19 ends. And so parents and guardians can continue their nutrition screening, and they have access to linkages and referrals for health centers, the VHT's nutrition services on their own. And so they can continue to screen and seek services on their own even after the activity ends.
Thanks, Andy. Let me end the Q&A. Please do check in the Q&A box. A lot of the questions have been answered in chat in case your question has not been verbally answered. Thanks to the presenters. Before you leave, please take a brief evaluation of our session today. There's a link shared in the chat box. We should be wrapping this up in 2 minutes. So please take some time to go to the link in the chat box and give us your feedback of this session. We have other sessions lined up during this learning event. Today, we have a collaborative sessions touching on 3 issues. Please do find time to sign up and attend those. There is one about engaging community service providers. There's one on community engagement for humanitarian response. A lot of interesting stuff. We're still on until tomorrow. So we encourage you to subscribe to the other events and themes and sessions. But for today, thank you, everybody. Please take time to give feedback on our session today. I apologize if we're not able to answer all your questions, but I think there's been effort to try to get most of them answered. Thank you, everyone. It's been a good morning or afternoon, mid-morning, having all of you on board. And I wish you a good rest of the week.